Well, hello, and welcome to this HCPLive peer-to-peer discussion. My name is James Fang. I'm the current president of the Heart Failure Society of America and professor-in-chief of the cardiovascular division here at the University of Utah. And I'm joined today by Doctors Parag Goyal and Eiran Gorodeski. Today's discussion is centered around the HFSA's recent scientific statement on cognitive impairment in patients with heart failure, which my colleagues served on as the lead co-authors. Before we begin today's discussion, if each of my guests could introduce yourselves to our audience.
Absolutely. So my name is Eiran Gorodeski. I'm a heart failure cardiologist in Cleveland, Ohio. I'm the director of the Advanced Heart Failure and Transplant Center at University Hospital's Harrington Heart and Vascular Institute and a professor of medicine at Case Western Reserve University.
And hi, my name is Parag Goyal. I'm a heart failure cardiologist at Weill Cornell Medicine in New York City. I lead our heart failure with preserved ejection fraction and cardiac amyloidosis program, and I'm an associate professor.
Fantastic. It's obvious that we have two authorities in this particular area of interest to our patients and our providers. So let me start with the first question. Can you share your insights into the collaborative creation process of this statement on cognitive impairment and heart failure? What motivated the decision to focus on this particular area?
Absolutely. So any clinician that takes care of patients with heart failure knows that patients have cognitive impairment. The problem is that even though cognitive impairment in this population of patients is very prevalent, probably more than 70% of patients with heart failure have cognitive impairment. Most clinicians who take care of patients with heart failure are not trained in how to assess cognitive impairment and find it. And many people struggle with the what's next? What do you do with these patients? And I think that HFSA recognized this conundrum, and this is what triggered the desire to produce this scientific statement. Parag?
Yeah, I do want to really give a lot of credit to the Heart Failure Society of America for recognizing this is an issue that clinicians face all the time. This is an issue that patients are facing. And so to commission a statement like this, to really find the right team, and I think it was a wonderful team that we got to work with, to go through the literature, understand the issues, outline the issues, and take it a step further and outline, well, how do we manage cognitive impairment? How do we make decisions? I think is really great. The team, working with the team, was really fantastic. Of note, I will share that Dr. Gorodeski and I have known each other for many years, and we've been having conversations about what to do with these patients with heart failure and cognitive impairment for many years. To have the opportunity to outline some guidance and put forth was really an amazing experience for us. And we hope that clinicians will find value in the guidance we provide.
I also think that what was really neat is that the authors of this statement are all clinicians who take care of patients with heart failure. And what we brought forward was real world practical experience. So there's a lot of clinical pearls for the practicing clinician in the statement. It's not like a theoretical, highly academic endeavor. It's really practical, and hopefully it brings value to HFSA and our readers.
Yeah, this is squarely in the Heart Failure Society's lane about trying to improve heart failure care and frankly, reduce the burden of heart failure on our society and our patients and their providers. And, your comments and insights are absolutely right on. Well, can we ask then, how can clinicians navigate the complexities of decision-making for advanced therapies in patients with heart failure with cognitive impairment in light of the really complex decision-making that is required for advanced therapies and frankly, end-of-life care? Either one of you.
Yeah, so I think that the first thing that clinicians need to recognize is that for many patients with cognitive impairment, their cognitive impairment is not going to be obvious. It's going to be nuanced, and it's very easy to miss. For many patients with heart failure, cognitive impairment is invisible. And unless we make an extra effort to test for it, it's very likely that many clinicians will miss it. And the risks of missing cognitive impairment when it's there is the opportunity to potentially intervene, not only by looking for causes that contributed to the impairment, and if you treat it, it could reverse it, but also the opportunity to accommodate and help the patient. For example, patients with cognitive impairment have a harder time to manage their disease. Self-management is difficult. So, patients with heart failure usually are on 8 to 10 medications. They have to follow a complex regimen that includes, modifying their diet and going to appointments and, checking their own vital signs. Well, patients with cognitive impairment will have a hard time doing that. And we'll need to find ways to accommodate for that. So for all these reasons, just the fact that, we're encouraging clinicians to look for it, and we explain what tools can be used in the statement, tools that are very easy, they're very quick. I think that's the first step to navigating the complexity.
Yeah, and as it relates to advanced therapies like heart transplant and left ventricular assist device, I'll comment to say that cognition is critically important for managing a heart transplant and taking your immunosuppression and showing up to doctor appointments, and is critically important for managing a left ventricular assist device. And so thinking about how these impairments are present, but at the same time, thinking about how these therapies might actually reverse some of that impairment by improving blood flow to the brain is an important consideration. I think there's opportunity for research in this space to really understand what aspects and how to identify reversibility of cognitive impairment. At current time, it's really challenging to figure out how exactly this fits into the evaluation process. It's certainly important, but how exactly do we use that information? And we outline some of this in the statement. I'll expand a little bit to say, in fact, I believe cognitive impairment, and really the authors believe that is applicable broadly, not just to the decision-making as it relates to advanced therapies, but also decision-making in terms of medications and overall management. As mentioned earlier, I lead our heart failure preserved ejection fraction program and cardiac amyloidosis program. We do a mini cog on every patient that comes in, and my clinical decision-making on a regular basis is influenced by how they do on that mini cog and understanding where their limitations or challenges are as it relates to self-care, medication management, and it helps me be a better clinician and partner with the patient to figure out what they need to thrive with this condition.
One way that I use the mini cog, which is slightly different, but I think would still be of interest, is testing people's cognition before they're discharged from the hospital after an admission for acutely decompensated heart failure. There's data that's published, and we discuss this in the statement, that patients with heart failure and cognitive impairment who are being discharged from the hospital have nearly twice the risk of being readmitted within a month as compared to those without cognitive impairment. And it's not that surprising, right? I mean, these patients go home, but their ability to self-manage their disease is limited by their cognition. So, recognizing that is important, and it may be an important intervention to reduce hospital utilization.
Yeah, so I wanted to get both your takes on the family, the caretaker, the spouse, the partner, in not only helping us as clinicians identify this issue, and you guys have nicely outlined some of the instruments that could be used, but to help us also manage the cognitive impairment. Just a few comments from both of you about that.
Yeah, so in this statement, we try to provide some practical guidance, some practical advice as to what we clinicians should be doing to help patients with cognitive impairment. And we outline 3 key pieces. One is to treat underlying contributors or causes. The other 2 are to engage the patient and family members and to accommodate challenges in self-care as much as possible. And so activating or engaging family, caretakers to help, say, fill pill boxes for patients, or to bring patients to appointments and share some of their own observations or insights, I think can be incredibly helpful.
Eiran?
Yeah, I agree with you, Parag. I think that when cognitive impairment is present, activating the social circle is critical. We really need to leverage these partners, and a lot of times, you know, the social circle is not aware, and for many patients and families, there's initially also that feeling of not wanting to get into, you know, the patient's business. But the truth is that they have to get into the patient's business, because the patient is at risk because of the cognitive impairment. So I think that the clinician really has a role of really being a moderator, informing the social circle, the family, the friend, that the patient will have difficulties self-managing, explaining to the patient that it's important to bring in help and therefore kind of defray any feelings of discomfort or embarrassment. We have to set the stage. And again, that's dependent on even recognizing that the cognitive impairment is there.
Yeah, and you both have contributed to the literature too about the virtual visit and the ability to see patients in their own homes and in their own settings, which I think this issue of cognitive impairment often becomes highlighted or even evident, particularly as you see them in their environment with their families. So, well, do you have any questions for me?
Yeah, so I had mentioned earlier, I want to thank you and HFSA for commissioning this, and the hope is that this will really truly provide as a practical guidance for clinicians. One question I'll ask to you as the president of HFSA is, how is the society planning to support clinicians in implementing some of the recommendations that have been outlined in a scientific statement like this?
Yeah, no, thank you for that question. You know, well, it first started off with support of this scientific statement. When this was proposed to us, I think the society, in particular the board of directors, felt this was really critical to get out there. But how are we going to advance this topic to our patients and our providers? One, of course, is getting the word out, education. So through publication of this very important statement in the Journal of Cardiac Failure, as well as posting it on our website, I think will go a long way toward that. Social media, of course, we're behind in terms of getting this out into the public. Then I think very importantly, we hope to highlight this at our annual meeting, because it is such an important topic, and scientific statements like this really need to be highlighted at our annual meeting. And then finally, we're putting together a registry of heart failure clinics across the country. And we're going to be providing criteria for what makes a quality heart failure program, and some attention in this statement to dealing with cognitive impairment, I think will be a big part of the heart failure clinic registry criteria that we put forth. So we're really looking forward to this, and I can't thank you both enough for putting this together. I read it personally, and it's very well written, and I think very useful for the typical provider caring for patients in this environment. Well, this really concludes our discussion about this very important statement. I want to thank you both, Dr. Parag Goyal and Dr. Eiran Gorodeski, for putting this together, and I'm looking forward to speaking to y'all again at our next meeting. Have a good one.